evening, everybody. Thank you very much for giving up your time on this rainy, well, it is in London anyway, Tuesday evening. And I'm delighted to present Mr. Parag Jaiswal, who will be presenting on the hip and the knee, sports injuries in the hip and the knee. Just a bit of housekeeping first. I'm Lizzie. Most of you have probably seen us before and may have even seen Parag speaking before. But essentially, Scan, for those of you who don't know, is like the booking.com for medical diagnostics. So if you're seeing a patient in clinic or you're doing a second opinion and you need a scan and you don't know or you don't have existing relationships and you want to book a fast access online booked scan, then you can come to our website and you can sign up and you will be able to refer your patients for scans. If you're not a doctor or a clinician, or even if you are, but you don't feel fully comfortable making imaging referrals, you can be assured that once your referral is submitted, our team of internal clinicians will review your request and make a chat to the patient really quickly and make sure that the imaging request is the right one for the presenting complaint. And then the patient will be scanned and your results will be available in your portal after they've had the scan. And you can also request and share the images. So if you want to know more, just click on the QR code. The only other point to mention is just be as interactive as possible. Please ask questions throughout on the chat, and we'll be asking you some questions, so please answer them. And at the end of the session, we do provide a certificate for your CPD for your continual professional development. So without further ado, I'm going to hand over to Parag. Thank you so much, Parag. I know that you've given up lots of your time to speak to our audience, but they always are very well received, and we're excited to hear what you're going to talk about this evening. So I'm actually going to stop sharing my screen, and whilst I do that, if everybody could answer the first polling question.
Great. So we have a lot of physiotherapists, some osteopaths, a couple of GPs and sports therapists. Excellent. I think this talk will be hopefully interesting for all of you. So my name is Parag Jaiswal. I'm a consultant in trauma and orthopedics with a special interest in sports injuries of the hip and knee. I do a lot of keyhole surgery in both of these joints with the aim to preserve the joint. So firstly, thank you to scan.com and Lizzie for inviting me to talk on this topic, which I'm really passionate about. I'm going to try and make it interactive, and so please do take part in the chat. In fact, even, and we'll answer some questions at the end. So I'm going to talk about sports injuries of the hip and knee, something I'm particularly passionate about. I've just done 2 or 3 operations today on both of those things. So a little bit about who I am. I was one of the first academic clinical trainees on the Stanmore rotation, which involved a 6 to 7 year training program. And during this time, I did a lot of research on cartilage injuries in the knee, which received a number of prizes and publications. Following my training, I had a tremendous year in a joint reconstruction and sports injuries unit in Calgary, in Canada. A massive center for skiing as well. And that was probably one of the best years of my life, both professionally and family life, because my family went there with me. Following that, I spent another period of time doing a hip fellowship at Frimley Park, which is one of the army bases where I learned a lot around the hip arthroscopy side of things. I was then appointed at Guy's Hospital as a locum consultant. I then did another traveling fellowship where I really fine-tuned my surgical skills with Mark Philippon and Richard Sedman Clinic in Vail, Colorado. All of this experience culminated in my current substantiated position as a hip and knee surgeon at the Royal Free Hospital NHS Trust, where I have a special interest in developing the young adult hip pathway and also sports injuries in the hip, and in particular cartilage injuries in the knee. So the aim of this talk and the objectives would be at the end to understand a differential diagnosis of patients young patients presenting with groin and hip pain, understand how articular cartilage injuries in the knee and meniscus injuries present, and obviously know the key features in the history, the examination, and various operative techniques that we now utilize. So you'll be happy to know that young adults are now aged between 16 and 55. And as I approach 50, I'm sure that will increase as well. And hip pain in this age group is not normal. Imaging studies, and usually it's x-rays, are quite often reported as normal. And persistent pain in this age group, it really does warrant further investigations. In the last 15 to 20 years, hip arthroscopy in particular has really improved our understanding of the causes of hip pain and how we can treat them to high standards. So the most common area of pain in patients that present with articular hip problems is anterior groin pain. And this is usually related to hip movements. So if there is pain in the anterior groin that's not related to the hip position, one needs to exclude non-orthopedic causes. This is a great diagram which shows a tremendous amount of overlap of the presenting complaint. So whilst almost 90% of patients present with groin pain, this is intra-articular hip pathology, and almost 90% present with groin pain. About 2/3 will also have lateral hip pain. The groin pain can often radiate down the thigh, and in some patients may only exclusively present with knee pain. A certain proportion, dependent on their kind of pathology, so for example, a pincer type impingement may present with buttock pain too. So differential diagnosis of hip pain in young adults can be separated into orthopedic and non-orthopedic causes. And the three most common are femoral acetabular impingement, hip dysplasia, and probably towards the end, sort of 40 and 50 age group, osteoarthritis. These two conditions predispose to a labral tear, which has its own set of characteristic type of pain. You may see this, stress fractures, more commonly around January to April time as people step up their training for the London Marathon. And we'll talk about AVN and some of these other orthopedic causes. In my practice, have seen quite a few patients with non-orthopedic causes that was excluded first. So I saw patients that have had hernia surgery and the groin pain hasn't got better. I've had some patients that have had hysteroscopies for presumed gynecological pain, and actually they had groin pain that was related to hip pathology, and vice versa. They've been referred to my practice for hip pain, and actually I think they have had a surgical problem. If a patient has a labral tear, some of them present with very characteristic, what describe knife-like pain in the groin. And this typically occurs after a period of increased or unaccustomed activity, but also it can begin sort of insidiously and slowly progress. The pain, also, although is initially activity related, if it progresses, it can be constant. It's typically felt in deep flexion movements. So gym goers complain of the fact that they can no longer do squats or lunges to the level that they like. And particularly around this area, around the Hampstead area, they may complain of difficulty getting in and out of their sports cars. As I mentioned, the symptoms as they progress, it can occur when they're just simply standing or just walking. Some patients also complain of a popping or a locking sensation, a grinding sensation, or a catching sensation if the labrum is completely floppy and entrapped in the joint. So as I mentioned, hip pathology can, all kinds of hip pathology can present as anterior groin pain. Features are suggestive of avascular necrosis or osteoarthritis even, typically has an insidious onset, is worse on weight bearing than simply walking, and relieved by rest. As the arthritis or the AVM progresses, they complain a lot of stiffness. Typical things they talk about is difficulty putting shoes and socks on, or getting in and out of a bath. And then as the disease progresses, they get pain in the night that disturbs their sleep. One needs to be wary of the stress factor if there's been an unaccustomed overuse and an increased intensity in their physical activities. As the pain goes more medially into the groin, one needs to exclude osteitis pubis, which is inflammation of the symphysis pubis. And this typically occurs in people that do a lot of kicking sports. And then also adductor injuries, if there's been an incident where they've played football or rugby, and the pain is very much in the medial thigh. And this may be associated with tenderness too. One needs to also exclude sportsman's hernia, or which is also called Gilmore's groin. This is where there's an injury where the abdominal muscles merge into the pelvic girdle. And this typically can occur when there's a lot of twisting movements or pain on coughing. This is a good summary of differential diagnosis related to the location of the hip pain. And as I mentioned, anterior groin pain in the younger age group, you need to exclude these two things, but be wary of AVN. And iliopsoas tendon problems can also occur in the younger age group. That's more of a snapping type, internal snapping picture. Piriformis syndrome can cause, piriformis entrapment is a form or cause of deep gluteal space syndrome, and it can also be a cause of hamstring origin pain or hamstring origin tendinopathy. So some red flags to ask for patients if they're having pain that's preventing sleep at night. You need to exclude OA, AVN, but potentially tumor as well if it's come about slowly and is unremitting in the night. If they're unable to weight bear, one needs to exclude stress fracture, but also bear in mind tumor and infection. We saw a fair amount of neglected trauma during COVID, and I saw a couple of cases of non-union and malunion of hip fractures, which was quite a tricky operation to do. If there's been a recent increase in weight-bearing activities, one needs to consider a stress fracture. And the best way, although you can get x-rays, the gold standard for excluding all of these is effectively an MRI scan. If they have pain on prolonged sitting, that may be labral irritation. Childhood problems are a risk factor for FAI. So if patients have had a previous slip, upper femoral epiphysis in their childhood, that almost has 100% chance of getting FAI in the future if it was not reduced or there was a severe slip. Steroids and excess alcohol are the two biggest risk factors for avascular necrosis. And if they have pain in multiple joints or constitutional symptoms, they probably need to be referred to a rheumatologist to exclude an inflammatory arthritis. All orthopedic examinations have a standard protocol of look, feel, move. Patients typically describe a C sign. They grasp the groin and say the pain is felt here. They may walk with a limp. The main area to feel is a greater trochanteric region, to exclude greater trochanteric pain syndrome, which quite often coexists with any hip pain. I very rarely perform a tenderness around the adductor tendons. That's quite an intimate examination. But if you just ask the patient to point with a finger as to where the maximal area of pain is, and that'll give you a clear idea. So with the patient supine, I roll the thigh, and that's called a supine log roll. That's quite a sensitive test for severe arthritic hip. You also then ask them to straight leg raise and then press against the thigh, so resisted straight leg raise. That's quite a sensitive test for milder symptoms or milder disease in the hip, as the joint reaction force is increased fourfold using this test. The number one movement to go in any intra-articular hip problem is internal rotation, and you test this with a hip inflection at 90 degrees. The Federer test or flexion, adduction, and internal rotation is also called the impingement test, and that's quite a good test as well. Correlates well with findings during hip arthroscopy. There's a video on my website on London Hip Knee. I did this video during COVID. This is Mr. Bones that we used to describe the examination findings with my registrar, so you can have a look on that. And I'll talk to you about femoroacetabular impingement. So this is defined as an abnormal contact between the femoral head-neck junction and the acetabular rim. This abnormal contact then leads to repetitive damage to the labrum, and there are two main types. There's a cam type where there's extra bone at the femoral head-neck junction, or a pincer type where there's overgrowth of the acetabulum. And then obviously you can get a combined type. Now, an observational study in Holland determined that almost 20% of patients that suffer from groin pain have FAI, and they basically concluded that an awareness of FAI in identifying patients may benefit their treatment. And even to this day, it's surprising the number of patients I see, particularly in the NHS, where they've been having persistent groin pain, which has been dismissed as effectively a muscle strain. And then by the time I see them, they've had such repetitive trauma to their labrum and chondrolabral junction that they've effectively started to get arthritis. This video demonstrates how a cam type impingement with this extra bone on flexion and then internal rotation causes damage to the labrum here. The labrum in cross-section looks like a triangle and is attached to the chondral surface of the acetabulum. And so as you can see, with the repetitive damage, the chondrolabral junction also starts to separate off the bone from the acetabulum. And this effectively is early osteoarthritis. And similarly, a pincer type impingement causes the same thing, but the other thing that it can cause is a contra-coup damage. So you get also damage to the posterior labrum and acetabulum, because as this abuts the femoral neck, the femoral head goes posteriorly, and this can cause buttock pain too. So that's something to be wary of. So we talked about look, feel, move. We talked about sharp knife-like pain, and these are the features that potentially can that you need to look out for. Get squats and lunges is the main thing. Rest pain is a bad sign, because that effectively means that they're starting to get arthritis. Movement, examination, antalgic movement, pain on straight leg raise, and reduced internal rotation. Federer test is positive, and then the Faber, which is a flexion, abduction, and external rotation, can lead to some stiffness in the groin, and that's something to look out for too. As I mentioned, radiographs, unless you know what you're looking for, are very often reported as normal. So GPs get lured into a false sense of security that there's nothing wrong. But as I mentioned, if they have persistent pain, they need to be referred to an orthopedic specialist, and then we can do an MRI scan, which is the gold standard. About 20% of patients in my practice end up getting a CT scan with 3D protocols and slices through the knee and ankle to give me a rotational profile. Because if a patient has a flexion and internal rotation of 0 and an external rotation of something like 90 degrees, which I quite often see, that asymmetrical rotational profile suggests that they have a retroverted femur. And the opposite to that is if they have 80 degrees of internal rotation and nothing of external rotation. And typically these young adults would say, oh, they used to sit in a W fashion as a child. That means they have excessive anteversion of the femur. So if patients present acutely, they need to modify their activity levels and have anti-inflammatory and would be referred for physiotherapies, focusing on mobilizing their hip and stretching tight structures and gradually increasing their flexibility. This involves also doing core and gluteal strengthening exercises and then progressing to better control of hip muscles. We know that patients that present with femoral acetabular impingement and labral tears do significantly better with physiotherapies. If we start the baseline here, physio gets them to there, but 2 really good randomized trials have shown that the surgery can get them to there in selected patients. These are the FATE and FASHION trials, and I was involved in recruiting patients in the FASHION trial. The results suggested that hip arthroscopy did better, and there was a high crossover as well. So what do we do in hip arthroscopy? So the 2 main things to do with the labrum are either labral repair or debridement. And we know from the national, the non-arthroplasty hip register, the NAHR, that repair patients do better than debridement. This is quite a bold thing to do, where surgeons actually detach the labrum from the acetabulum and then trim the rim of the acetabulum, so that's acetabuloplasty, and then reattach the labrum. And then femoral osteochondroplasty is basically shaving away of the bone at the femoral head-neck junction, which happens in all patients. A little bit about DDH, developmental dysplasia of the hip. Again, this is a spectrum, and in the very mild conditions, X-rays can be reported as normal. It can present in adolescence with mechanical groin pain, which again is activity related. Patients can present with a limp, leg length discrepancy, clicking and popping. Lizzie has a hand up.
I do. You've got a couple of questions. Do you want to take them now, or do you want to mosey on through? There's one that says, is steroid hip injection a risk factor for AVN, or is it more with oral steroids?
So the answer to that is it's oral steroids, usually for prolonged doses. So if patients have had it for a week or so, it's not so much of an issue. But I have seen a lot of patients with asthma or COPD, and they've had 30-day courses, or patients with chronic conditions.
Thank you. And then you've got one that says, what orthopedic test can differentiate between pincer type from CAM in FAI?
You can't. There's no orthopedic test. So the main test is for hip impingement is the Fadir test. We can't differentiate between whether it's pincer or CAM. That will be delineated with an X-ray or an MRI.
Okay, so imaging.
Yeah.
Great. So, and would you advise that they refer to you before imaging that, or that they image straight away?
I think, well, the patient pathway would be probably, I guess, if they had the MRI scan and I see them, then I can make the diagnosis there and then. The only thing I'll say is that sometimes I do like a weight-bearing X-ray, so I can do that on the day as well.
Okay. So referral basically.
Yeah.
And then you've got a couple of questions. How would you treat symptomatic osteitis pubis failed to respond to conservative management?
This is a horrendous problem to treat. And I tend to refer them to my good colleagues, my sports physicians. Um, and they can manage them pretty well. The main thing is that these are quite athletic individuals, and you have to just get them to stop exercising so much. We have done injections, and very rarely, very, very rarely, we've done fusions, but it's not a great operation.
Okay. And also, how would you manage a hip in a young adult with ligamentous teres, significant tear following suspected dance injury, failed to respond to conservative management?
Yeah, this is again also a very difficult problem to treat. I haven't done ligamentous teres reconstructions. That's quite a niche operation. I tend to just debride the torn ligament. It usually has two bundles. So usually one bundle is torn, the other I retain.
Okay, cool. And what can the prognosis long term in terms of hip stability be for that? For ligament?
Yeah. So typically, the ligamentous teres tears occur in hypermobile patients. Um, so with my hip arthroscopies, the other thing to be wary of is if we do an interportal capsulotomy, that can lead to instability as well. But I don't do that. I do limited capsulotomy at my insertion sites. I don't connect the two portal sites. So I have far less instance of instability in my patients. But with the ligamentum teres, yeah, I don't tend to do the reconstructions, and they seem to be okay.
Great. And let's let you carry on for a bit, and then we'll take Christoph's question, unless you want to answer it now.
Okay, well, I can do that now. What would you consider treatment options for posterior intra-articular hip impingement? Um, yeah, this is also a very difficult problem to treat, but I have done an accessory posterior portal, and if the labrum is completely torn, I've been able to repair it. And if there has been significant cartilage damage, I'm doing microfracture less and less, and there are more novel cartilage regeneration techniques that I'm learning and doing.
Thank you.
Great. So I'll briefly talk about DDH. This is one of the biggest risk factors for a labral tear. The treatment is similar to FAI, but also different. The key thing, as we kind of alluded to, is to prevent iatrogenic instability. So the Americans used to do large interportal capsulotomy, and they didn't repair the capsule, which led to significant microinstability, despite repairing the labrum. The other thing to be careful of when you're doing the acetabuloplasty is not to resect too much, because then you will lead to further instability. So in my practice, I do limited capsulotomy, and I do at least 3 or 4 anchors to really stabilize the labrum. It can be a very difficult access because the labrum in these patients are really hypertrophied, and sometimes you have real difficulty getting into the joint. This is contrasting pictures. One on this side, you have over coverage and pincer type impingement, and here you can see under coverage of the femoral heads. And so they're two very different X-ray findings. Quite often you have something in the middle, and as I mentioned, X-ray findings are often reported as normal. And we classify hip dysplasia according to X-ray findings of the lateral center edge angle, so a vertical line from the center of their head, and then the corresponding angle that's at the most lateral aspect of the acetabulum. But by and large, we tend to do MRI scans, and then CT scans are restricted for certain patient groups. Treatment is conservative nearly always. However, that if they have mechanical symptoms suggestive of labral tear, it is highly unlikely to work. I tend to offer them a hip arthroscopy with a view to, and it's really paramount to really try and repair the labrum. If you don't, in this patient group, there's a high chance that the labral debridement will lead to early onset arthritis. If the center edge angle is, well, 15 degrees or 16 degrees, they always need a PAO or periacetabular osteotomy. And there is a gray area between the center edge angle of 16 to 20 degrees. And that kind of has a more bespoke treatment pattern. So here we have a patient with bilateral DDH, and then a periacetabular osteotomy, which involves breaking the pelvis in 3 places and then realigning the socket so that there is better coverage. This has really good results in good hands. This is a good case history of a 35-year-old female who's a former elite swimmer. She had a history of childhood hip dislocations, and she presented actually in my NHS practice with a 3-year history of groin pain, which worsened with night pain. She had pain on flexion beyond 90 degrees. She had fairly good internal rotation, but pain at the end range and FADEA was positive. On my video, there's a good section on how to do a provocative test for labral tear, which looks almost brutal, but it can be quite useful. So you can see she had a center edge angle of 45 degrees. And these are the arthroscopic findings. So this may not make sense to you, but this is the femoral head, this is the acetabulum, and this is the labrum. You can see my probe here pushing on the labrum. You can see the tear at the base here. And you can see here, I've gone all the way around. This is the posterior aspect. This is the chondrolabral junction. And you can see here the labrum, which is repaired. You got 1 suture here and 2 more anchors here. Sorry, 1, 2, and then the 3rd anchor here. So that's a labral repair with 3 anchors. And then you can see this excess bone now. This is at the femoral head neck junction. So she also had a cam. And then here you can see the femoral head. Some debridement has already taken place of the femoral head neck junction. This is the head, and you can see the labrum here. And you can see the concavity has been restored. And then we did a dynamic test to make sure there's no impingement. So that's hips done. Are there any questions on hips? Any more questions? Okay, so I'll go on to knees and cartilage and meniscal injuries.
Thanks.
So I sound like a geek, but I really love synovial cartilage. Having written a 75,000 word thesis on it and spent 3-4 hours defending my thesis, you've got to love it. The reason why I love articular cartilage is that it's one of nature's truly amazing features, and we as human beings have not been able to replicate anything like it. It just allows smooth, friction-free movement, for up to 70, 80 years. And the key feature of articular cartilage is the extracellular matrix, which is made up of type 2 collagen. But there are other structures which contribute and have different effects. Interestingly, chondrocytes or cartilage cells only make up 5 to 10% of it, and they're involved in synthesizing new cartilage. And they're influenced by a variety of growth factors and cytokines. The important thing about articular cartilage is that it has no connection to blood supply or, in fact, any nerves, which is why if you have a good volume of cartilage, then patients don't feel pain. It's only when the cartilage gets thinner and thinner, where more bone is exposed, which is very rich in nerve endings, that patients complain of pain. And then why articular cartilage injuries do not heal is because they have no blood supply. So if there is damage to articular cartilage, there is no blood flow, growth factors, and healing taking place. So if a patient presents with an articular cartilage injury, in my practice, both in the NHS and privately, the history is really in the modified Cincinnati score. And so this is available on my website. If you go to londonhipknee.co.uk, and then under patient information, patient forms, there are a number of other scoring forms, such as the IHOP 12 for hips as well. And this really gives you a good history. Most patients present with pain, some may present with swelling, and some may present with giving way. So all patients that present with cartilage injuries in the knee, in my practice, fill out a modified Cincinnati score, and that gives you a global overview of how their knee is functioning at one particular moment in time, and then we follow them along longitudinally and get them to fill in scores. Examination-wise, quite often they'll present with an effusion. There may also be tenderness or pain, tenderness along specifically where the osteochondral defect is. Most common areas are medial femoral condyle, but you may also get lateral femoral condyle and also retropatellar region. You should also palpate along the joint line for concomitant meniscal pathology too. Clearly document the knee range of motion, and also test for the collateral ligaments by valgus and varus stress, and obviously the ACL ligament. The main provocative tests I do now is a Thessaly test, which involves a single leg stance on the affected side with the knee flexed to 30 degrees and rotational movements. So effectively, you're getting the patient to do their own McMurray's test, which is a much kinder way than you inflicting pain on them. So when articular cartilage injuries occur in the knee, they heal with scar tissue formation, which is deficient in type 2 collagen. This has inferior biomechanical characteristics and has lower load-bearing capacity. It's quite a big problem. And you see articular cartilage injuries in up to 2/3 of patients that are having keyhole surgery for whatever reason. It may be for meniscal tear, it may be for ACL tear. Any patient that presents with hemarthrosis, 25% of them are likely to have an articular cartilage injury. A number of different surgical procedures can be undertaken, from a simple debridement to microfracture to mosaicplasty or autologous osteochondral transfer. AC Macy's had a fairly good outcome, and then a newer technique which I'm utilizing in my practice is a single stage cartilage regeneration technique, or PACE or AutoCAR. So debridement involves just simply removing unstable cartilage. And this is because cartilage around an osteochondral defect is abnormal and produces matrix metalloproteinases, which causes further inflammation. And simple excision of this lesion has been shown to improve outcomes for 5 years in isolated defects. Debridement in osteoarthritis, we know, is contentious. Microfracture was introduced probably over 30 years ago now. It involves debridement of all unstable cartilage down to subchondral bone, with an awl used to make multiple holes to stimulate healing. And this is a curette removing these unstable cartilage. You can see the bone, underlying bone exposed. This is the awl making some holes. And once the tourniquet is released, you see this nice bleeding coming into the defect. A modification and probably advancement of that technique is where you do the microfracture and then you use fibrin glue and stick on a collagen synthetic scaffold, which has the advantage of retaining all that blood clots and all the good stuff in that defect, which is obviously an advantageous thing to do compared to just simply allowing it to just go all around the knee. And we know the results. Here's an example of us doing it. We know that the results are superior now to microfractures. In my practice, I very, very rarely do microfracture alone. Mosaicplasty was first described by Hangodi in Hungary, and in fact, I'm going to Budapest in June to present on cartilage injuries. This involves taking cylindrical plugs from a non-weight-bearing area and impacting it in a press-fit pattern into the weight-bearing area. Here's a good example of that in the trochlear groove. And this is an arthroscopic picture. And you can see that the defect fills in nicely between the cylindrical plugs too. Autologous chondrocyte implantation has been around for many years now. And as I mentioned, I wrote my thesis on this in 2007, or started on that. And it's been going on for a long time. Initially, we used a periosteum patch. We then went on to collagen membrane. And now the latest advancement is MACI, which is where we stick it on with fibrin glue as opposed to putting sutures in. This is a two-stage procedure. In the first stage, which is done arthroscopically, cells are harvested, sent to a lab. They are then expanded and cultured. And then in MACI, they're seeded in a type 1-3 collagen membrane, has a rough side and a high density side, and then we just stick it back on with fibrin glue. The rehabilitation is really, really long, and there are 3 distinct phases. The most critical is the initial implantation phase, where you need to protect what you have. And in this phase, the cells stick onto the bone and they proliferate. And this phase takes 8 to 12 weeks. And the first 6 is very critical. I typically limit weight bearing for 6 weeks. And in fact, I put them in an extension for the first 2 weeks and then gently allow them to move. The transitional proliferation phase tends to occur from about week 10 to 12. And there's a gradual increase in their activity levels so that they can then start doing recreational activities such as swimming, cycling, elliptical work. And then the maturation phase occurs much later. So depending on the type of cartilage repair, the return to sports is significantly delayed with AC, which is why patients, particularly really pro athletes and Premier League footballers, for example, end up having microfracture because the return to work is much quicker. This is a good algorithm. It's slightly outdated now because with lesions of greater than 4 centimeters, nearly always they go to AC or OAT. And I've added in the 2.5 to 4 centimeter age group autocart, which is a fairly new and exciting technique where cells are harvested from the lesion and they're curetted, as you saw with the microfracture picture, and then the cells are put into a paste, the chondrocytes, and they're stuck on with fibrin glue. If that doesn't work, one of the newer things is a synthetic osteochondral defect substitute, and I've used this in limited patients. The prerequisites, I mean, for autocart and even for Mayogen is typically done in femoral defects. I have extended it into the patella as well, but the important thing is in correct malalignment, ensure there's no ligamentous instability, and make sure there's no meniscal problems. If there's been significant meniscectomy, then probably the patient isn't suitable for it. But I have done it concomitantly with meniscal repairs. The key thing is that it can be done arthroscopically, and it has a potential for higher-like cartilage repair. And it's a single-step procedure as opposed to AC or MACI, which is obviously a lot more cost-effective. Okay, this is a great case study of a 30-year-old male who injured his knee a year ago, and he had an MCL injury on the MRI scan. During COVID and lockdown, he did lots of running, and then he twisted his ankle and knee, which led to a lot of knee swelling, stiffness, and giving way. He had a number of lesions. So you've got a retropatellar large lesion here and here in the trochlea. I think this is a lesion in the lateral aspect, and there's also a lesion in the posterior aspect. So MRI findings, yeah, femoral trochlea, medial femoral condyle, lateral femoral condyle, and loose bodies. So I did an arthroscopy, and I had autocart on standby, and this is what we found. So he had two osteochondral defects in the trochlea. He had osteophyte formation already in a 30-year-old. He had a medial femoral condyle lesion, a lateral femoral condyle lesions, and then we removed two loose bodies. These are the loose bodies that we removed. This is a medial femoral condyle. This is a defect. I had to, in the end, convert to an open procedure in order to get all of those access to all of those areas. So this is the defect filled with minced cartilage. This is the lateral side. Again, this is filled with minced cartilage. And this is the trochlea. You've got two areas here. You can see this large osteophyte here. The osteophyte was removed, and then this has been filled again. And he had a modified Cincinnati score of 50, and 6 months down the line, his modified Cincinnati score is now 84, I think. So I'll talk about meniscal injuries. These can be traumatic or degenerate, and sometimes there's an overlap between the two. There's different types of meniscal tears. So you have a longitudinal vertical tear, you have a radial tear, you have a horizontal tear, you have a parrot beak tear, which is very difficult to treat, a flap tear, and then obviously the bucket handle tear, where patients present acutely with a locked knee. You have an anterior and a posterior root, and that can get avulsed. This is most commonly seen with ACLs, and you can have a combination of the two. The meniscus has a blood supply, has three distinct zones. So the red zone is where it's attached to the capsule, and this has a good blood supply. And then the white zone is closer to the articular surface, and this has no blood supply. And then you have a red-white zone. Depending on the type of tear and the age of the patient, nearly always they have rest, ice, medication, and physiotherapy, certainly in the NHS. However, I think if patients are young, and particularly if they have a lateral meniscal tear, I'm a big advocate for going in early and trying to repair it, on the clear understanding that it may not be repairable. The rehab is obviously longer with a repair versus partial meniscectomy, but I really always try and repair the lateral meniscus. I've had a couple of cases where patients have had surgery elsewhere, and then the lateral meniscal repair has failed, and the patients presented with a bucket handle tear, and I've gone back in and again did my best to try and repair them, and that's worked pretty well, because I tend to use a mixture of not just all inside repairs, but also inside out, which is a much more robust repair. Initial treatment involves weight-bearing x-rays as always, but MRI is the investigation of choice, and onward referral is ideal. And we are working, and I'm working with scan.com and doing knee assessment packages where patients can be referred, have an MRI scan and see me, and then we can get an answer very quickly. This is a great case of a chronic meniscal tear. You've got a 27-year-old female who injured a knee a year ago. She got better with physio, but had ongoing swelling after any kind of activity, particularly doing extreme movements in yoga. And she's really fearful of any twisting sports such as tennis, which she wanted to return to. And then the knee would also give way. And here you can see this is a lateral meniscus, posterior horn, anterior horn. You've got a tear extending all the way through the articular surface, fluid is then going through this one-way valve and causing an anterior meniscal cyst. And she's done very well from meniscal repair using an inside-out technique. This is a 34-year-old male from America. He had a lateral meniscal repair at the age of 20. He then had, I think from memory, had another arthroscopy almost a year later, but he doesn't know what happened then. And he's playing with his knee and playing with his daughter, and his knee got stuck in 60 degrees of flexion, and he couldn't move it. I was able to get an MRI scan on the day, and he's then subsequently had surgery. I think almost 2 or 3 days later. I had to do a hybrid operation where I removed part of the meniscus, and then I did repair of the other meniscus. So you can see a suture here, which has basically closed this horizontal tear, and another one here. And here's a probe on the back of the meniscus, and I'm pulling, and you can see the meniscus stays there. And here at the end, I always take a picture to show the patient that the knee can be fully straightened, whereas before it was stuck in 60 degrees flexion. So what about knee arthritis? This is a fairly new, I'd like to talk about arthroscopy, which is a fairly new injectable gel implant, which I've been doing in patients, and this is having some really fantastic results. It's used as an alternative to a total knee replacement, for example. It's a non-biodegradable gel implant, which is injected under ultrasound guidance, and then it coats the synovium and integrates with it to suppress inflammation and provide a cushioning effect. The initial study showed fantastic results with 80% success rates at reducing WOMAC scores, which are maintained at 3 years. So to summarize, and I've gone through it fairly quickly, but I want to really have a nice discussion at the end of this. With hips, persistent groin pain following an injury, or even insidious onset, wants further investigations, and ideally MRI scan is the investigation of choice. Meniscal and cartilage injuries can grumble on. Obviously, bucket handle tears present with a locked knee, and therefore they will get seen quickly. But if you see ongoing grumbling pain in these patients, again, probably warrants further investigation. And we are doing hip and knee assessment packages to try and get to the bottom of what the patient's diagnosis is. And then arthroscopy injection really represents an exciting, non-invasive way of treating patients with knee arthritis effectively. And I spoke to Andy Murray, surgeon in Melbourne, who did his hip arthroscopy. And this was a great example of how he should not have let his grumbling groin pain carry on. But, you know, he was winning Wimbledon at the time, so he didn't want to have major surgery. Great. I'll take questions now. Thank you.
Thanks, Parag. That was great. We've had a few questions come in since we interrupted you the last time. One, Cheryl was asking if she can have notes, but I think are you okay to share the presentation afterwards?
Yeah, I gave a PDF of my presentation.
Yeah,
I think I forwarded it to you. Yeah.
We'll share that afterwards. And so we've got a couple of live questions, which I'm so sorry for not getting to. I didn't realize there was 2 chats open, but why surgery quicker than lateral meniscus tear versus medial meniscus?
Yeah, so that's a good question. The lateral meniscus has a much better, the lateral meniscus has a more pivotal role in distributing forces through the knee, and increases the concavity of the joint. That's why it's a more important structure to retain, because if that goes, it's almost 100% guarantee of arthritis in the future in that compartment. The medial meniscus typically, and the other thing to say is lateral meniscus is more mobile, and that's why it's important to try and retain it. Whereas with the medial meniscus, you can get away with a partial meniscectomy and delay arthritis. So, and not have arthritis in the future, if that makes sense.
Yeah, that does. And then Peter Gray has asked you, please explain the inside-outside technique.
This involves, so with an all-inside technique, you basically have a device that pierces the meniscus, goes through the capsule, and you deploy something that stops, it's called an anchor, it just stops it from coming out. And then you just pull on the suture, and then the meniscus gets pinned back to the capsule. With an inside out, you basically get a needle that goes through the meniscus on the inside and comes out through the capsule and then comes out through the skin. Then you deploy another needle with the same suture and comes out through the skin, and then you literally can tie the suture. You basically do a knot tie and pin the meniscus down, and you can adjust the amount of tension, and it's just a much more robust technique, and basically not relying on an anchor that's pinned onto the capsule.
But you're tying through the skin, is that right?
Well, you make a skin incision.
Yeah.
Into the capsule, then you tie it onto the capsule, and then you close the skin over.
Okay. If DDH is picked up at newborn and treated, is there any risk for future hip pathology, or do they have a similar risk to the general population?
So what we're talking about there is congenital dislocation almost, or dislocatable hip. This is the classic Barlow and Orthopaedic tests. If you have hip that's dislocatable in an infant and is treated early enough, either with bracing or with surgery, there is a lower risk of arthritis in the future. What we talk about with DDH is a spectrum where you've got the socket and the ball, and then as you go from adolescence to adulthood, and the hip is growing, it's not growing properly, and you have like a shallow acetabulum, so the femoral head can go up and down and increase motion. And what tends to happen is you get point loading here. That is a big predisposition to arthritis. And what happens in these patients is that you have a femoral head that's not covered. So then this area here is covered by labrum, which gets hypertrophied, which then predisposes to getting torn in the future. I think that answers the question right here.
So basically, they do have a increased risk than the general population.
Yeah.
Gemma has asked you, what do you think of supplements? And if anyone has a strong view, please put it in the chat as well. Joint supplements, sorry, not just general supplements.
Yeah. So the scientific literature is not very clear. However, what I tell patients is it's a commitment if you're taking glucosamine, chondroitin, turmeric supplements, right? And you need to take them daily, and then maybe 2 or 3 times a day. 1 second, my laptop is about to run out. Back. So, what I tell patients is take it regularly for 3 months. And if you feel there's a significant improvement in your symptoms, carry on taking it for life. Now, there are a number of confounders to this, right? Because in that 3 months, they'll be doing activity modification, they'll be doing exercise, they'll be losing weight, hopefully. And therefore, the knee symptoms or hip symptoms will be better. But, you know, I'm a strong believer in placebo too. So if a patient believes it's going to work and it works, carry on taking it. The key thing is that there's very little side effects, and it's a low risk thing.
Yeah, that makes sense. The next question was, are there any issues with patients who don't get relief with, oh God, I'm going to pronounce this wrong.
Arthroscopy.
Yeah, thank you. Having surgery, i.e. does the arthroscopy, that's how I'd say it, cause any problems if the patient needs knee replacement?
Well, the short answer to that is well, there's two answers to that. Firstly, in my practice, I don't know. Because I've not done knee replacements in patients with previous arthroscopies. However, I have gone to Copenhagen where it's manufactured. I've spoken to surgeons. I've done my due diligence, and the initial study of over 100 patients, I think 4 or 5 needed knee replacements, and I've spoken to the surgeons and the rheumatologists, and they said there were no issues regarding this. So patients are safe and free to go ahead and have a knee replacement if required.
Okay, makes sense. When would you consider operating on loose bodies?
Typically when they have, it depends where the loose bodies are. So if there's a loose body behind the posterior cruciate ligament, I tend not to go after that. The risks of surgery far outweigh the benefits. But the main symptoms that loose bodies cause are catching and giving way. So I would typically offer surgery in those patients. And on the proviso that I may not be able to get rid of all of their loose bodies. But the main things are mechanical symptoms, so giving way, locking, and persistent swelling after activity.
Then it's a couple of complimentary remarks, and then it says, very interesting, especially reference to the lateral meniscus. Okay, sorry, that's just another one. So can you say something about post-knee pain? Or KNNE pain? I think it is knee pain. I have a lot of patients who get this without evidence of gastrocnemius, soleus injury. Is it usually post-horn referral? And do you, with meniscal injuries fraying in the middle age, plus just allow to settle down? Finally, with these injuries, if symptom-free, what is your opinion of returning to running? Questions in one.
Okay, so
that is wishful thinking.
okay, let me see if I can dissect that. So posterior knee pain may be related to irritation of a number of things within the knee. Okay, so for example, I get this too actually, and I've had to stop running. If you have, and I can speak from personal experience, shearing of retropatellar cartilage, your knee gets irritated, and the knee, when it gets irritated, only knows one trick, which is form more fluid. And if you have a lot of fluid, it can go into the Baker's cyst, and patients complain of posterior knee pain secondary to Baker's cyst. Those patients do well if there's also synovitis with aspiration of that fluid and injection of steroids. I don't like giving steroid injections, but that's one of the few rare indications where I would advocate doing it. So that's one potential cause, which is basically a Baker's cyst secondary to irritation for whatever reason within the knee. A meniscal tear can also cause irritation in the knee, and post-meniscectomy, usually partial medial, patients can get persisting pain because of cartilage damage or instrumentation within the knee. And again, sort of 6 to 12 weeks, I've given them a shot of steroids, it's calmed them down. That is then important to then see you guys, i.e. the physiotherapists, a week afterwards, then do the strengthening and muscle training program and get the knee range of motion back.
Makes sense.
Did I answer anything else? Fraying in the middle age. So meniscal injuries in the middle age, if they're not causing any mechanical symptoms, then I don't chase after that meniscal tear. So if they're not causing clicking, giving way, or locking, I would treat it again with a steroid shot, give you a pain-free window, and then start physio. I tend not to do repeated steroid injections. We know from the literature that repeated steroid injections can lead to a reduction in native cartilage volume. I have done hyaluronic acid injections to good effect as a good way of pain relief without the steroid side effects.
How many steroid injections have that effect, or is it just all of them?
So the literature does show there was a reduction in cartilage volume was on an MRI scan, and those patients had probably an injection every 3 or 4 months for 2 years.
Okay, so it's quite a lot. It's not just a
That's
couple.
quite a lot, yeah. I typically restrict it to 1, maximum 2 in a year. But as I mentioned, I think I prefer to give hyaluronic acid injections, which tend to last longer. And now I've started to give arthroscopy injections for basically patients with a lot of synovitis, because we know that the arthroscopy really binds well with the synovium in those patients.
Okay, makes sense. I hope that's your question answered. Can you explain the screw home movement of the knee?
That effectively, basically, when you go from a flexion to an extension, and when it locks, there's a little bit of external rotation. And that effectively is down to a number of ligaments and basic science behind it. I don't think I've enough time to go through what the ligaments are and what's involved, but basically involves slight external rotation on full extension.
Thank you. And do you have advice? Do you advise physical therapy on palpable fibrous deposits in medial compartment? Lots of runners present with these palpable tissues.
I'm not entirely sure what those fibrous deposits are that you're alluding to. But I do know a lot of patients do really like manual therapy and hands-on therapy. So I would say go ahead with it if patients are feeling better. Comment.
Okay. And then the last question we have at the moment is, please enlighten on the role of PRP in the knee.
Yeah, that's also a great injection. I do use that a lot in my practice. For those that don't know, PRP is where you take blood, centrifuge it in a machine to isolate the plasma component, which is rich in platelets. The mechanism by which it works is basically, as I alluded to, with cartilage and chondrocytes, they respond to growth factors and cytokines. And so platelets secrete growth factors. Now, there'll be a number of private clinics in London that will say this is magic and it leads to cartilage regeneration. That's simply not the case. And I know FRCS is on the case of these clinics to shut them down. But what it does do is that it does prevent further cartilage breakdown. And it has an anti-inflammatory effect. So I use PRP in my practice for patients that are kind of sporty. They may have had a post-meniscectomy procedure done, and there may be some chondral damage, but nothing that requires cartilage regeneration techniques surgically. And so I typically offer them a course of 3, a week or 2 weeks apart. There's a great chapter written by my BSc, my registrar. So we've done a good overview of this. And what we've learned is that the most efficacious is a course of 3, 1 to 2 weeks apart, and it's more of a chondroprotective thing. So in my practice, I've done it in patients with meniscal repairs on the day, arthroscopically, and I've given them 2 further shots a week, or sort of 6 weeks post-operatively. I've also done it in patients for labral repairs. And I've done them for simple cartilage damage, particularly patellofemoral area as well. The other thing to tell you about is that patients should not take any anti-inflammatory medication. So ibuprofen, naproxen, for the duration of that PRP treatment and for 2 to 3 weeks afterwards, because it has an effect on platelet function.
That makes sense. And just moving to, what's that question? how long after PRP and CSI do you recommend physiotherapy?
PRP takes a bit longer to kick in, a week or two. For corticosteroid injections, I typically tell, even for hips and knees, wait a week and then start physio after a week.
Okay. So 1 week, that's pretty quick. And can you also just enlighten a little bit on the role of shockwave in patellar tendonitis?
Yeah, that's my go-to actually. I tend to refer patients with patellar tendonitis either to physiotherapy straight away, or to one of our sports doctors. But shockwave is probably the first line, along with activity modification. Like these patients, they're typically runners, jumpers. They love their sport, and the first thing to do is just get them to rest and start the physiotherapy program, and then start shockwave for refractory tendonitis, even in the greater trochanteric region as well. And if no further improvement, we can then think about dry needling and injection of PRP into the tendons area.
Okay, that's great. I think that's all we've got. And we've run over slightly, so I don't want to keep everyone, but if you have any more questions, please send us an email. Fantastic attendance. I think we were up to about 80 or 90 people on this call during the call. So thank you for giving up your time, and thank you, Parag, for joining us again this evening. We'll circulate for anyone that wants it, a certificate and the slides as well. So thank you so much, everybody, for joining.
Great. Thank you, everyone.
Thanks, guys.